now begin Lecture 23, Digestive System number 3, Midgut, Hindgut, and Gut Rotation. So the midgut will have derivatives, and again they are supplied by the superior mesenteric artery, and they are suspended by the dorsal mesentery. The midgut will produce the small intestine and the large intestine to the midpoint, actually the distal 2/3 with the remaining 1/3 of the transverse colon. So what are the derivatives of the midgut? It's the lower part of the duodenum. We've seen this already. The jejunum, the ileum, the cecum, the vermiform appendix, the ascending colon, and then the proximal 2/3 of the transverse colon, as I said. So it ends at the distal 2/3 point of the transverse colon. So there is a herniation and a rotation, as we will see in Figure 12-13, and this occurs in weeks 6 through 10. So this occurs because of course, the abdomen is crowded with the developing liver and kidneys, so they're quite large relative to the overall size of the abdomen. So as we get elongation of the midgut, we get a ventral loop. We've seen this in previous lectures. This loop will herniate. There's only one place for it to go, so it goes into the umbilical cord through the opening between the intraembryonic and the extraembryonic coelom. This midgut loop is going to rotate 90 degrees clockwise around the axis formed by the superior mesenteric artery. The cranial end of the loop comes to lie to the right, and the caudal end of the loop comes to lie to the left. So this initiates the rotation. So we will be taking a look at Figure 12-13. It's a schematic, a series of schematic drawings that illustrate the rotation of the midgut as seen from the left side of an embryo. So around the beginning of the 6th week, there will be the midgut loop in the proximal part of the umbilical cord, and then with the transverse section through the midgut loop, we will see an illustration of the initial relationship of the limbs. There's a proximal and distal limb of the midgut loop to the artery, superior mesenteric artery. And then we'll look at a later stage showing the beginning of the midgut rotation, and then the 90-degree counterclockwise rotation that carries the cranial or upper limb of the midgut to the right, as we stated, and then at about 10 weeks showing the intestines returning to the abdomen, and then finally an illustration of a further rotation of the final 90 degrees, an additional 90 degrees, and then about 11 weeks after return of the intestines to the abdomen will be that final 90 degrees to give a total of 270 degrees of rotation. And the later fetal period will see the growth of the cecum rotating to its normal position in the lower right quadrant of the abdomen. So here is panel A. In A1, we are seeing the axis of rotation, the superior mesenteric artery, here, right down in this loop. So there is a cranial limb and a caudal limb of the midgut loop with the superior mesenteric artery as the axis. The first rotation will be cranial to the right and caudal to the left. So it goes from a vertical position to a horizontal position, and that's illustrated here in A1. So our other structures that we've described previously are all present above here. We're now focusing just on the midgut loop. We note that the yolk stalk now is quite attenuated and small, and it is again at the junction of the cranial and the caudal limbs of this midgut loop. We go to panel B, and again we are reminded of the rapid growth in length. So it now has herniated into the umbilical cord. We are in that first 90-degree rotation position, as shown in B1 here. So the The caudal limb is to the left, the cranial limb is to the right. So there is continued rapid growth of the cranial limb, and recall that the stomach is pushing to the left posteriorly and to the right anteriorly. So this is occurring at the same time you're getting this great elongation of the cranial limb of this midgut loop. So what happens is the duodenum, as you can see, gets pushed behind the mesentery, plastered against the posterior abdominal wall. So the majority of it becomes secondarily retroperitoneal, had the dorsal mesentery and lost it, and is covered on its anterior surface with a visceral peritoneum or serosa, posterior surface covered by adventitia. We'll see this again and again as we continue through this portion of the lecture. So this elongation pushes the duodenum, the distal duodenum where it joins the jejunum, to the posterior body wall and over to the left. And we are still in that 90-degree rotation. So we are herniated into the umbilicus. We can see the cecal diverticulum is started, so we know that this is the colon all the way over to the transverse proximal 2/3 meeting distal 1/3, and then finally the rest of the hindgut, as we will see. So this is a transverse section through the umbilicus. So here we see the neural tube developing, the spinal column developing, and structures in the posterior body wall. And we are going to zoom in on this box here in just a moment. But what we notice, and of course, this is the stomach, this is the duodenum, and this is the liver. And then we see on the ventral body wall a defect. It hasn't fused completely. This is obviously the umbilical cord, and we have herniation of the midgut loop into the umbilical cord. So now we can zoom in on that box, and we see the duodenum, the epithelial lining, and then the rest of the mucosa, the submucosa, and the muscularis, and then the serosa developing out here. The pancreatic duct is seen passing through the wall. We don't have the complete appearance of it, but a portion of it passing through the wall of the duodenum out into the developing pancreas. So what is meant by the rotation and the retraction of the herniated intestinal loops during development? So the rotation is that the parallel with the growth in the length, the primary intestinal loop rotates around an axis formed by the superior mesenteric artery, and it occurs in a counterclockwise direction. So the cranial loop going from 12 o'clock to 9 o'clock, so that's counterclockwise. Retraction is ultimately, at the end of the third month, the herniated intestinal loops will begin to return to the abdominal cavity due to the expansion or the growth in the entirety of the abdominal cavity to accommodate it. So we said that in general there is a rostral to caudal development, rostral structures developing more rapidly than caudal structures, so ultimately the abdominal cavity will develop in size and will accommodate the entire gut loop. So the return to the abdomen then in week 10, this is the reduction of the umbilicus. The abdominal cavity increases in size. The livers and kidneys are relatively reduced or absolutely reduced in size. There will be a rotation, and then the return will cause the duodenum, the pancreas, and the ascending colon to become secondarily retroperitoneal, and we'll follow that through figure 12-15. So here we see the retraction, the reduction of the umbilical cord by the retraction of the gut loop from it. And we see the small intestine, which was the original cranial loop, is on the left side. We have another 90-degree turn here. So we're now at a full 180 degrees. So this has come over to the cecum is now into the full upper right-hand corner of the abdominal cavity, just below the liver. And so the transverse colon is going to be continuous with the hindgut, so it ends up being strapped across in front of all of the structures in this area, basically the gastroduodenal junction, the duodenum itself, so the upper portion and the lower portion of the duodenum, and then the duodenal junction, the duodenojejunal junction, all basically will be covered by the transverse colon. And we know that the dorsal mesogastrium will grow and elongate and flop over this transverse colon ultimately and extend down in the abdominal cavity and become the greater omentum. So we get the return back into the abdominal cavity, seen here of the small intestine, forms these tortuous twists and turns until the ileum meets the cecum. We see the vermiform appendix forming there, the transverse colon on over to descending and sigmoid colon, the last two of the hindgut. And then the final 90 degrees of the turn is the descent of the cecum with the appendix from this upper right-hand quadrant to the lower right-hand quadrant, the normal neonatal and adult position of this. We see the anastomoses here within the greater omentum of the branches of the superior mesenteric artery and the celiac trunk. We said that both share the blood supply to the duodenum. We see the rest of the superior mesenteric artery giving all of its cascading branches to the midgut portions, which includes the remainder of the small intestine and the large intestine from cecum through the ascending colon over to the 2/3 of the proximal transverse colon. And then the hindgut, of course, is here descending sigmoid and rectum. So with figure 12-15, we'll look at the fixation of the intestines. We'll take a ventral view of the intestines prior to their fixation, their final fixation in place, and then a transverse section at the level from this panel A. And we'll see areas of subsequent fusion of the dorsal mesentery to the posterior body wall. So had a dorsal mesentery and lost it. So we know we're talking about the process of producing a secondarily retroperitoneal structure. And then in C, we'll look at a sagittal section at the plane, again shown in A. Another view illustrating the greater omentum overhanging the transverse colon, as we just indicated. And we will see the areas of subsequent fusion there. And then finally, from a ventral view of the intestines, we'll see with the transverse section after the disappearance of the mesentery of the ascending and the descending colon. Then finally, in the sagittal view, we will see the fusion of the greater omentum with the mesentery of the transverse colon and fusion of the layers of the greater omentum. So here we have the stomach, greater curvature with the greater omentum extending from it, the common biliary duct with the pancreatic ducts opening into it, as you recall, the gastroduodenal junction here, and then the duodenum is plastered against the posterior body wall, going behind the colon, and then emerging here in the midline at the duodenojejunal junction. And so we have returned to the abdominal wall, the retraction and reduction, and as well we're getting the final 90-degree turn as the cecum will descend into the lower right-hand quadrant. So we're going to follow the progression of events. After this, the ascending colon has been created and put in place. It'll lose its mesentery. The transverse colon will persist with the mesentery, but the greater omentum is going to fuse to it. The descending colon will lose its mesentery. The sigmoid colon will, S-shaped here, will sustain a mesentery attachment, a dorsal mesentery attachment, And obviously, the virtually all of the duodenum will lose its dorsal mesentery. So we see this here in this horizontal or transverse view. The jejunum will sustain a dorsal mesentery, whereas the ascending colon is going to be pushed against the posterior body wall and we'll get a fusion fascia, as it's called. We lose the mesothelial membrane, so the parietal peritoneum now will come and reflect up here and then onto the surface, becoming visceral peritoneum, and then onto the posterior body wall to become parietal peritoneum, and then on mesentery proper here on out to become visceral peritoneum on that structure. The descending colon gets pushed to the left body wall, vertically positioned from upper left quadrant to lower left quadrant, where it joins the sigmoid colon, the S-shaped portion that curves over and goes into the pelvis. We see that a fusion fascia is going to be formed here. Had a dorsal mesentery, lost it, covered only on its anterior surface by serosa, posterior surface by adventitia. The descending colon is secondarily retroperitoneal. In panel C, we see the two layers of the greater omentum going through a similar type of effusion, extending over the transverse colon, and we get a fusion of the dorsal mesogastrium back near its attachment to the posterior body wall, where the pancreas was, where the duodenum is pushed back to form a secondarily retroperitoneal structure. And we see a fusion between the dorsal mesocolon, transverse mesocolon, and a portion of the greater omentum, the dorsal mesogastrium. Collectively together, they will then be called the transverse mesocolon. And we see the ileum suspended in the greater omental sac. Remember, this is the lesser omental sac back here. Everything else is the greater omental sac. Although it's covered with visceral peritoneum, there is a persisting dorsal mesentery, so it is a mesenteric structure. So the transverse colon is a mesenteric structure. The ileum, jejunum ileum, are mesenteric structures. The duodenum, as an example, is secondarily retroperitoneal, therefore. So let's take a look at the greater omentum again, but just quickly, the small intestine that we see here, the jejunum and the ileum, we see the mesentery proper. They are mesenteric structures. Had the dorsal mesentery, kept it, always were and always will be mesenteric. The ascending colon is secondarily retroperitoneal. Transverse, we saw the transverse mesocolon. You notice the flexure on the right side is near the liver, so it's the hepatic flexure. So at that point, mesentery, the dorsal mesentery becomes persistent again. So we have a transverse mesocolon that fuses in part to the greater omentum, as we said. Over in the left flexure, it's near the spleen, so it's called the splenic flexure of the large intestine. And as soon as it takes that turn, we get a fusion fascia, so it is secondarily retroperitoneal throughout the length of the descending colon. As soon as the sigmoid forms, there is a sigmoid mesocolon, so it is a mesenteric structure. We end up producing adult features, as we see here. For both the ascending and the descending colon, we see that there are little gutters on each side of it. Again, parietal peritoneum here, and then it reflects up onto the surface, anterior surface, forming the serosa of the wall, or the visceral peritoneum. So where it reflects up on is a paracolic gutter. So there's two paracolic gutters on the left side for the descending colon, and the same on the right-hand side for the ascending colon. Again, the greater omentum is a site for fluid accumulation, pus accumulation if there's an infection. So these features and their nomenclature are very important for communicating such issues clinically. And then we see the fusion of the dorsal mesogastrium, the greater omentum, that is, with the the transverse mesocolon, becoming basically the transverse mesocolon, and then the fusion of the greater omentum, two layers together, so it's a single layer uh, suspended within the greater omental sac. So when does the mesentery of the jejunal-ileal loops become separated from the mesocolon transversum? So we can toss a little Latin in there. So around the sixth embryonic week, when the caudal limb of the ansa, the loop umbilicus, moves to the right side of the abdominal cavity, and the dorsal mesentery twists 90 degrees counterclockwise around the origin of the superior mesenteric artery. So which parts of the intestinal caudal canal, develop from the primary intestinal loop, and which artery supplies them? So the jejunum, ileum, cecum, appendix, ascending colon, proximal two-thirds of the transverse colon, and Meckel's diverticulum, and it's the superior mesenteric artery that gives them the blood supply. So now we can talk a little bit about abnormalities of the midgut rotation. And the first we see is a malrotation, so it can be a congenital omphalocele persistence of the physiological herniation, so the persistent umbilical herniation. And this can include the midgut and or the liver, and it requires surgical reparation. The umbilical hernia, a typical type, it is failure of the umbilical opening to close after reduction of the physiological herniation. So this is herniation after reduction. This is failure of reduction to be completed. Gastroschissus, so a schism is a split. When there's a schism between two countries or two political groups or members of a family or a team, there is that split, and it is of great concern. So clinically, when you have a schism, it's not a good thing either. So this is a defect in the anterior abdominal wall, so it is laid right open. The peritoneal cavity or the greater omental sac is exposed to the external environment. So it's beyond where the umbilicus would be. So it allows the abdominal contents to herniate into the amniotic cavity in males. This is greater than females, and most common wall defect that we see, and it's caused by the incomplete closure of the lateral folds during week 4. So we could almost have predicted that. Other malrotations, non-rotation, so you have a left-sided colon. Failure of the midgut to rotate upon reduction may involve volvulus, or a torsion of the gut, just gets twisted way too much and contracted and occluded, and you can see the obstruction of the superior mesenteric artery, so you can get necrotic segments where they have lost their blood flow. So not a good thing. Meckel's diverticulum that we mentioned before, it's a congenital ileal diverticulum. It occurs in about 2 to 4% of the population, males again greater than females. And it typically is asymptomatic, or it can become inflamed with stuff just kind of collecting in there, and it is the remnant of the proximal yolk sac. So which of the following is the correct sequence of development of the small intestine? And we see it is the first one here: elongation, herniation, rotation, and return. And an omphalocele arises when the midgut fails to return, so that original physiological herniation persists. What is the Meckel's diverticulum? Describe its location and the developmental origin. So it's that outpocketing of the ileum located about 40 to 60 centimeters from the ileocecal valve on the anti-mesenteric border, so the ventral border. Dorsal mesentery persists as mesenteric border, right, of the ileum. One of the possible remnants of the vitelline duct. So what is meant by the physiological umbilical herniation, which occurs during the 6th week of the embryonic development? So as a result of the rapid growth of the primary intestinal loop and the simultaneous expansion of the liver, the abdominal cavity temporarily becomes too small to contain all the intestinal loops, so they enter the extraembryonic coelom and the umbilical cord temporarily. So now we can wind it up by talking about the hindgut. So there are derivatives of the hindgut supplied again by the inferior mesenteric artery. It is the distal half of the transverse colon, distal 1/3, let's say, to be consistent. We've been saying 2/3 before. Let's switch it to 1/3 remaining. 2/3 and 1/3 makes the whole thing, right? So descending sigmoid, rectum, and the anal canal. So the epithelium of the urinary bladder and the urethra will be formed through this mechanism as well, the urachus, basically. It ends caudally at the cloaca, which divides to the rectum, the anal canal, and the urogenital sinus. And by 8 weeks, it becomes continuous with the amniotic cavity. So here we see figure 1225 from the textbook, and it's the classic midgut where the yolk stalk is located, and we can see the hindgut caudal to this point of the yolk stalk coming back, invisible or imaginary line projecting back here. So this is all hindgut all the way into the cloaca in this area here, remembering that the cloaca opens into the allantois. Then here we see in panel B, a bit closer view, and we recall here is the cloacal membrane, so the proctodeum is this space, and the cloacal membrane is closing off these future openings in this area. It's more than just the anus, the anal canal, as we will see. Some of the mesoderm or mesenchyme is positioned between the allantoic stalk and this portion of the hindgut that enters into the cloacum, and this is called the urorectal septum. We will follow that septum as it pushes down in through here and divides things up. So if we took a section through this area here, we can see that there is an infolding of the cloacal wall due to mesenchyme ingrowth in this area. We proceed along to see that the urorectal septum is pushing in a little bit farther, the phallus would begin to develop around this stage, and the cloacal membrane is kind of rotating up and having a more anterior facing feature. We know that ultimately it's going to swing around and have an inferior angle straight down. So here we see the proctodeum as this space. This is panel B from this rectangle. This space is the proctodeum, and this is the cloaca, and the urogenital septum is continuing to push down in to separate the urogenital sinus from the rectum. So this space is divided by the mesenchyme pushing in to separate it physically. And we see that here, this constriction is getting ready to close off the urogenital sinus from the developing rectum through the infolding of the lateral walls of the cloaca. And then here at a much later stage, as we had mentioned, we can see the urogenital septum. The urogenital septum here has pushed all the way to the point of fusing with the anal membrane or the cloacal membrane, and it separates the cloacal membrane into an anal membrane and a urogenital membrane that we'll talk about with the development of the urinary system for these areas here. Obviously, this becomes very important for development of the reproductive system as well. But for now, we're just going to focus on the hindgut formation for the digestive system. So we see again the proctodeum is becoming more limited in its boundary definition, if you will. The urogenital membrane is this upper portion of the original cloacal membrane, and it is produced by the urogenital septum fusing with the cloacal membrane, separating that urogenital one from the anal membrane that covers the future anus. And of course, the mesenchyme on the lateral walls of the cloaca now has pushed through and met in the midline and completely separated the urogenital sinus, future urinary bladder, of course, from the rectum. Good thing to separate the two of those. So here we see a horizontal section through the hind region of an embryo, and we can recognize the pubic bone primordium here anteriorly, the urinary bladder, kind of a thick wall to it beginning to form here, a ureter coming into the trigone, the space where the openings, 3 openings, 2 ureters, and the urethra that we don't see in this plane of view come together. Some contributions of the early kidneys that are related to reproductive system development, and we see a ureter off to the lateral aspects of the rectum in this area. So the rectum would be the only thing that you would have to be able to recognize in this plane of section. And we see that it has no mesentery, it is fused, it is retroperitoneal. So this illustration is a rather nice drawing showing the urorectal septum pushing all the way in, making contact with the cloacal membrane. And here we see now that the anal membrane is present. Obviously, it's going to have to become perforated to open this end of the digestive system. And we see urinary and urogenital system, let's say, developing in this area. We'll focus attention on that at a later time. So we see the rectum retroperitoneal, continuous with the anal canal and the anal membrane, separating it from the amniotic cavity, and the cloacal membrane completely separated into anal membrane and urogenital membrane by the urorectal septum, leading to this appearance in the adult. Excuse me. So we see the superior mesenteric artery coming off the aorta directly, with the superior mesenteric vein forming in this area as well. Both of them giving supply, of course, to the small intestine that's been removed. We see all the small branches here that would have been supplying the small intestine. The terminal ileum is here at the ileocecal junction, and we see the sphincter at this area here, the cecum, the appendix in the lower right-hand quadrant of the abdomen, ascending colon, secondarily retroperitoneal, transverse colon to the 2/3 portion, and the superior mesenteric artery and vein are giving supply to that. And then this is where the inferior mesenteric artery will begin to give its blood supply, as well as the inferior mesenteric vein is shown here. And the descending colon, sigmoid colon, and the rectum, all given blood supply by the inferior mesenteric artery and vein, neurovascular bundle in general. Here we see an enlarged view of the epithelial lining of the intestine, and actually all the walls, so the mucosa and the submucosa shown here, and the muscularis externa. And then on the anterior surface would be a serosa. On the posterior surface of the descending and the ascending colon would be an adventitia. But since we're looking at the transverse colon, it would always be a serosa, the visceral peritoneum. And then in the encircled area here, we can see the development of the lower rectum and the anal canal. Now there's an internal and an external anal canal. The internal anal canal is coated by or lined by an epithelium, a simple columnar epithelium, the same as the colon way up here. And that is of endodermal origin, as are the surface epithelial cells and the any types of glands that are produced from the endoderm in the large intestine. The anal sphincters, there's an internal smooth muscle one and then an external skeletal muscle one. Where those two are separated is where the anal membrane existed. So internal to the anal membrane would be endodermal origin, a simple columnar epithelium. External to it will be the external anal canal, contributed by surface ectoderm, and it would be a stratified squamous epithelium. So similar to where the buccopharyngeal or oropharyngeal membrane was, and we see that here in the female and the male, the bulge of the anal external anal sphincter on that. So this external anal canal would be lined by stratified squamous epithelium, and there would be a junction, a transition to the simple columnar epithelium of the endodermal origin. So again, there can always be abnormalities. So the first that we discuss is Hirschsprung's disease, or megacolia, or megacolon. And this is a distension of the colon and the failure of peristalsis due to the lack of innervation. And so this would be an aganglionic megacolia, failure of the neural crest cells to migrate in. So the postganglionic parasympathetic neurons would not develop. All of the somatodendrite and axons of peripheral resident neurons originate from neural crest cells, sensory and motor. Motor would be the visceral motor, and we see it fails to be developed here because the neural crest cells don't migrate into this mesenchyme to form the submucosal and the myenteric neuronal ganglia of the parasympathetic nervous system within the gut tube. So it's the most common of the neonatal obstruction, about 33%, and more common in males than in females. This doesn't always have to be a complete aganglionia. It can be a hypoganglionia, so a slight decrease with a little bit of distension and significant, quite significant constipation. And it also can be a hyperganglionia, hyperactive one, so on either side of this. But the Hirschsprung's disease, by definition, is the aganglionic megacolia, where there is no motility. So what are the derivatives of the hindgut? The distal third of the transverse colon, the descending colon, the sigmoid, rectum, upper part of the anal canal, urinary bladder, urethra, lower part of the vagina, and the prostate. So which organs develop from the cloaca? The urinary bladder, except the trigone, the urethra, prostate, lower part of the vagina, the rectum, the upper part of the anal canal. So these are the two that we're concerned with now. We will complete discussion of the others in the future. So define the word proctodeum, other than it being a person that is almost a perfect a-hole. Bad joke. And it would be an external depression opposite to the anal membrane formed by the mesenchymal swelling. So it's always been similar to the oral cavity. The term is escaping me for the moment. That general space in that area that will become the future opening into the area. So the proctodeum for the anal area. So this completes lecture 23.